questions.
Yes.
Do you have to use Noble implants for Noble Guide?
Yes.
Okay.
The kit is designed to go through the guide sleeve. The guide sleeve have precise dimensions, and they're 4.3, 5, and 6, which correspond with the mounts and the diameters of their implants. Nobel also has a 3.5 implant, and to place that implant, we have an insert that goes into the guide sleeve itself.
Right.
So it's one little, like a trailer hitch that goes into it, and then you would place the implant into that. So yes, you do. And I'd like to add, Maurice, that these implants are not special implants to guide. They're the standard Nobel system implants.
Correct. And the second question is, what mode of CAT scan are you using these days? What are you doing in your office? I know that we use an iCat machine in our office, and in your office you're using...
Yes, I have the same one, the Imaging Sciences iCat, and it was a pretty strong investment for me. I practice by myself, and I felt that this area of implant therapy is truly the future. And I do some lecturing, and I do practice, and I don't have time for errors and mistakes. Now, I know there are areas of the country where the technicians who have radiology centers do a great job. This is so specific and precise. The patient must have their scan denture with the gutta-percha markers, they must have their bite, and everybody must know how to sit down correctly, scan the denture afterwards correctly, because if not, by the time it comes back to me and I put the disc into my computer, that evening I'll find out that we have to do it all over again. And it's embarrassing, time-consuming, and time is money. So having this product in my office, it's the footprint of a panoramic. It's easy to learn. About 4 or 5 of my staff members know how to use it. I could internet data to a teammate in New York who wants me to check something out. We could put it on a key, we could put it on a disc, and it works very, very nicely for the data collection. It's a standard DICOM file system. This particular system also has what's called iCat Vision, which gives a rendition of the flesh of the patient, the skin tones, the contours. So if we're doing a case with an orthodontic colleague, we could see facial contours. We've done work with TMJ, so it's a very versatile device.
You can have a TMJ image, ortho image, you can have an implant section taken and printed in the file, given it to your colleagues. We've been using it for the last couple of years. Jack has, I think we've got almost at the same time, and I'd have to agree with Jack. This is the future of dentistry, there's no doubt. Within the next 5 to 10 years, the 3-cone imaging technology will be a rather routine part of work without it. I also agree with Jack. What he said is that simply sending it to your local radiology team is not going to give you the information you need, because the pre-prosthetic planning that goes into the surgical radiographic guide that needs to be worn during the procedure is so vitally important, and important that those, especially if you're using Noble Guide, that they also...
Exactly.
A lot of these imaging centers don't understand how to do that, and if they don't do that, it doesn't work.
Well, there's another thing about that. When we use the iCat, it's a sit-down, and we have a tray that the denture can sit on. So you must take the denture in the same plane that the patient was scanned at.
Right.
Many of the medical scanners are lying down devices, and then they have to put the denture onto a shoebox. Now, I don't know how many radiology centers are like wrapping things around and with the correct tape. You put the wrong tape on it, it creates scatter, just like we're doing with restorations.
Once it's off angle, then being able to sit that denture in the mouth correctly on the bone, on the scan, is very difficult. So that adds another aspect of possible problems in the future. You're talking about in the situations, I know it doesn't happen very often, but some people say I did it according to the guidelines and the case didn't fit or didn't go down all the way. How often does that happen to you in your experience? You have more experience than most, and what did you do in those situations?
First thing we do is we take the prosthesis out of the patient's mouth and go back to the master model. The master model was created from the intaglio surface of the guide given to the lab partner who precisely positions his analogs and components. This one case in particular, when we were putting it on and off, we noticed that there was a slight up and back movement. So we kind of got the actual movement that we wanted took it back to the mouth, and that indeed solved the problem. Okay, there's a couple of little pearls that the special guided abutment is a fastener abutment. It clamps to the top of the implant. It wedges against the internal sleeve of the prosthesis, and the restorative colleague must seat it all the way into the prosthesis.
Acts like a molly bolt.
Exactly. So when it's put in there, if it's not down all the way and you tighten it, it will expand in the sleeve, but it won't be down all the way.
Correct.
So it gives you a little torquing of the prosthesis, and it'll be out of occlusion.
Right. It'll give you a little latitude in terms of...
Well, no, if it's
off
clamped, then you
right.
can have a little bit of an adjustment. That's possible. But I'm talking about not putting it down.
Oh, no,
so
that's
that is, one of the things that can happen. Another thing that can happen that's now been eliminated is the earlier cases we did had a couple of little tissue tags right around the implant placement site. If you don't clean that out perfectly, the prosthesis will hang up as well.
Right. Tissue will actually keep it from seating.
Yeah, it's like two things can occupy the same space. So there is a guided tissue punch now that goes right through the guide, and it creates a perfect ring. Clean that tissue out, works out nicely. So these are things to like troubleshoot before you have any problem with giving up. I have never had a case that did not seat.